There is a note from Dr. Todd Blumberg that he had a really nice experience working with Curtis and Avery. I don't see either of them here, so thank you for that. I'll remind everybody that we have a lot of people typically watching remotely, usually about 20 to 30 more people. Another message from Julie Mandat that was sending us feedback on how helpful Prash, Remjit, Cody, Acom, and Madeline Jackson, Acom Dillon, and Cody Tipton, of course, were when she was working for them. Or any, oh, there's Prash. Thank you, Cody, thank you. Is anybody else there? Acom? No, okay. And then the last one was from Dr. Matt Thompson, and it was regarding Andy. Is Andy Hewlett? There he is. And Dr. Thompson said, this is a brief one, I wanted to reach out and thank Andy for the excellent feedback that I was receiving from the nursing staff on 6 Southeast. You were praised for providing clear communication and well-written postoperative notes. So thanks to all of our residents for their usual great care. This morning, it's my pleasure to introduce Dr. Matt Folchert, who you all know, and Dr. Paul Pottinger, who is our go-to infectious disease doctor extraordinaire for all of orthopedics, and also a mountain climber extraordinaire and a professor in the Department of Medicine. This talk was supposed to be given last February, I think, and that was Snowmageddon. And it was the only time I can recall that we had to cancel grand rounds, and being typical orthopedic surgeons, I got a lot of feedback that maybe that was being a little weak, but I think it was a wise decision given what was going on outside. And so we're glad that we have nice typical fall weather now, and Dr. Pottinger and Dr. Folchert are going to speak about preventing surgical site infections. And I'm really looking forward to this because there's been a lot of national conferences and consensus statements that have been issued, which have been somewhat controversial over the last year, particularly regarding the duration of perioperative antibiotics and regarding the use of adjuvants such as sterile betadine. So with that, Dr. Folchert is going to start grand rounds.
Hello, everyone. I'm Matt Folchert, fifth-year resident here at UW. I have no relevant financial disclosures. We'll be talking about surgical site infections. I myself will be talking more about hand hygiene and some of the things that we do before and during a procedure to try to reduce the risk of infection during surgery. So hand hygiene started in the 1800s with Ignaz Semmelweis. He's considered the father of hand hygiene. He noted that in 2 different maternity wards, one run by residents, the other by midwives, that the resident ward was almost had twice the rate of puerperal fever, and that's postpartum fever due to infections. At that time, they didn't know bacteria existed. He also noted that the residents often came from the autopsy suite and their hands smelled terrible. And he hypothesized that these cadaverous particles potentially were to blame for the infections that they were seeing. You have to remember at this time they didn't know bacteria existed, and so this was pretty revolutionary. He tried to get his colleagues to adopt his chlorinated lime hand scrub because he noted that when he made all the residents do that, the mortality rate dropped to 3, which is lower than the midwives ward. However, all his colleagues, didn't really buy into it. He became ostracized from the medical community, became very depressed. They actually admitted him to a psych ward. They beat him, and he died 14 days later from infection. So pretty terrible start to hand hygiene. It was a few years after this that Holmes and Lister in the UK also hypothesized a very similar hand regimen to reduce infections. And several years after they introduced that, it became widespread throughout the medical community in Europe. So he didn't quite live to see that, but he made a big impact. If we look in the US, the incidence of surgical site infections as documented in the National Healthcare Safety Network is approximately 1.9%. They looked across about 900 hospitals in 43 states. They looked only at index procedures. So for orthopedics, these are some of the index procedures that they look specifically at. The healthcare burden from surgical site infections is pretty significant. Of all surgical site infections, there's approximately 3% mortality rate associated with that. And if you look at those patients that develop a surgical site infection and die, directly attributed to their death, 3/4 of them are due to surgical site infection. They're also the most costly healthcare associated infection. In the US annually, it's about $10 billion of added cost due to all hospital-acquired infections. 33% of them are due to surgical site infections, so that's about $3.3 billion. The next closest is ventilator-associated pneumonia at about 30%, and so this beats C. diff, catheter-associated infections, central line-associated infections. It adds an additional 1 million days, inpatient days annually in the US, and approximately 10-day increased length of stay. And this isn't just a problem of the United States, it's across the world. Europe has similar rates of surgical site infection. And in 2011, it was estimated about half of these were preventable with appropriate practices to try to reduce and prevent surgical site infections. So one of the best resources to look at all things hand hygiene is from the World Health Organization. They made this in 2009, Guidelines on Hand Hygiene, 270 pages, goes over all the different things that you would ever think about for hand hygiene, which different products to use, different techniques, scrub length, gloving. So we'll go through some of the more interesting parts of this as it relates to surgical hand antisepsis. So one of the most interesting things I found was with gloving. This university hospital in Basel, Switzerland, looked at glove perforations and found that in this hospital, the surgeons only single gloved. They looked at all cases where it was noted that a glove was perforated and looked at the rate of surgical site infections. And they compared that to cases where there was no glove perforation at that. It was twice as high in the group where there was a glove perforation. They also noted that after a 2 hours or longer case, 35% of all those gloves had perforations, often microperforations, where 80% of them went unnoticed. And if you look at the latex gloves as they come from the manufacturer, 4% of them already have pre-existing microperforations. So this is why you should probably double glove. It reduces the rate of interperforations by 80%. The next thing I want to talk about are the different types of surgical scrubs. They come in two broad categories. There's surgical rubs, and those are alcohol-based. Those are the ones that you just rub on your hands and allow the alcohol to evaporate. And then there's the surgical scrubs. Those are the ones that are water-based, that you rinse your hands in the water from the sinks outside the OR rooms. And so the two goals of this are to remove any transient organisms that you may have picked up, on your morning rounds or just on day-to-day activities. And the second is to reduce the burden of your resident organisms on your hands. We all have bacteria on our hands, and so the goal is to try to reduce that as much as possible. And then kind of another secondary goal is to try to prevent their regrowth. Because when your hands are gloved, it's just the perfect environment for those bacteria to try to regrow. And so we'll discuss what the different options do to prevent that regrowth. So probably one of the most common ones is just the pure alcohol, the sterilium that you see in many of the ORs in our system, 85%. These alcohol ones come with emollients or things to help protect the skin. In the past, like 1940s, 50s, alcohols earned a really bad reputation because they didn't have those emollients in them, and so the hands after repeated use became cracked, fissured, and very dry. And so it kind of led to, at least in the US, moving away from these. But as they added these emollients, they become the most common hand antisepsis products in the world. The other option is adding some chlorhexidine. This is more of the gel-based. And then for the wet scrubs, we have the iodine scrub, the chlorhexidine scrub, and the PCMX, which these are all the products that are commonly used in our system. Just one thing I wanted to point out, they've looked at barriers to using some of these, and one of the most common is contact dermatitis or skin irritation. So when looking at all of these, iodine is the most skin irritating, followed by chlorhexidine, and then the least irritating is the alcohol. There's no good evidence on the PCMX, so I'm not sure where to put that one. If we look at alcohol rubs, typically in the US, they're about 60 to 80%. This is the ideal killing range for bacteria. If you have a higher percent alcohol, it actually needs the water to get to the proteins to denature them. And so that's why pure alcohol rubs are less effective than kind of this mid-range 60 to 80%. It's also why when you use alcohols, you have to make sure that your hands are completely dry. So if you do a wet scrub followed by a dry scrub with the alcohol, you want your hands to be dry because that's going to maximize the killing potential of the alcohol. It kills gram-positive and gram-negatives very well. And like I said, by denaturing the proteins. Fortunately, it has no activity against spores. And we'll talk about why it's important when you start the day to do a wet scrub to reduce any spores or encapsulated organisms that the alcohol might not kill. It does have a 99% reduction, or it's way higher than that, 99% reduction in bacteria, and this occurs in the first 15 seconds. But as it's on longer, it's more and more effective. But you're reaching kind of negligible amounts of bacteria within 15 seconds. There's no persistent activity, but like I said, it kills bacteria so rapidly and effectively, it takes 6 hours for the bacteria to even get back to the baseline levels. When we look at iodine, this is the wet scrub. There's approximately 1% free iodine. It comes in the povidone, which is a polymer that helps it prevent skin staining, reduces skin irritation. And also, as the iodine is used and becomes effective, it continually releases. So you always have a constant 1% free iodine, and it's that free iodine that makes it potent and kills the bacteria. It also kills gram-positive and negative, but it does this by penetrating the cell wall. It complexes with the fat and proteins and kills the bacteria. It too has no activity against spores. It does have some residual persistence, but it's only for about an hour, and then after that, the bacteria rapidly regrow. And we'll talk a little bit more about that with the World Health Organization guidelines, why that can be a problem, especially in a gloved hand. For the chlorhexidine, it comes in a wet scrub 4%, or the 0.5 to 1% that you see in some of the gels with alcohol. It kills gram-positive better than gram-negative, and that's because it disrupts the cell membrane, so the gram-positive are more susceptible to it. It too has no activity against spores. In an initial use, so if you've never used it and then you use it for the first time, it has about a 70 to 80% immediate reduction in bacterial counts, which is slightly superior but pretty similar to iodine. However, its main benefit is that it has persistent activity and it increases with each application. So as you use this throughout the day, and even each day consecutively in a week, it builds up on your hands and has a persistent effect. So if you use chlorhexidine every day, you likely have a residual amount on your hands, and it's always working, keeping those bacterial levels low. The PCMX comes in a 3% surgical scrub. I've seen it at the U. It kills gram-positive with fair gram-negative activity. It inactivates their enzymes. It's been around since the 1920s, typically used in cosmetics. There's not a lot of good data on it, and it's about as effective as chlorhexidine and iodine, probably a little less so, but comparable. It is absorbed through the skin, and that's why in 1994 the FDA reclassified this as unknown safety and efficacy pending further data. They've done some mouse studies, but those were ingested orally, and so it's just not very comparable to kind of the dermal absorption that is used in humans. It's most likely safe, they just don't have the evidence that it is 100% safe. If we look at actual scrubbing, using the brush side versus the sponge side, they've actually found that using the brush side creates higher bacterial counts than using the sponge, and that warm water enhances the effect of your wet scrub. However, if you use hot water, it actually increases the bacterial regrowth. And these are both thought to be due to stripping away of the fatty acids that are naturally protective on the skin. Traditionally, scrub times were thought to need to be up to 10 minutes, and this does result in initial higher reductions of bacterial burden. But by disrupting the skin's natural protective barrier and the stripping away of the fatty acids, it enhances the regrowth. So kind of the current thought is somewhere between 1.5 minutes and 3 minutes is the ideal scrub time to maximize your decrease of bacterial burden but minimize the regrowth. So the World Health Organization, I thought this was really interesting looking at kind of on a world scale, iodine, even though it's one of the most commonly used antisepsis products around since the 1800s, it has a higher rate of allergic reactions and doesn't have that same persistent effect that the alcohol, because it's so effective, or the chlorhexidine with its persistent activity does. And so they've found that at the end of a surgical intervention, if you have gloved hands that have been treated with iodine, the bacterial counts inside those gloves could actually be higher than before you even scrubbed, which is a little concerning if you were to have a glove perforation. Additionally, looking at arguments for alcohol disinfectants, if you look at, these are hands that have been treated with E. coli and then subjected to the hand antisepsis. The alcohol products have nearly a 10-fold increased reduction of bacterial burden compared to iodine or chlorhexidine alone. And then if you look at persistent activity in just the resident flora of hands, the chlorhexidine plus alcohol is twice as effective as just the chlorhexidine alone or the iodine. And after 3 hours, it still has pretty significant persistence and reduction of bacterial burden, whereas you can see in the iodine, bacterial levels get pretty close back to baseline. And to finish this out, I just wanted to discuss the CDC. They've reviewed all the literature from 1998 to 2014 in regards to reducing surgical site infections, and this is their kind of summary of practice guidelines to try to reduce surgical site infections. And this was recently updated in 2017. And so they classify the different recommendations of strength. 1A is a strong recommendation with moderate to strong evidence. 1B is strong recommendation with weak evidence, and then it goes down the line. So we'll only talk about the 1A and 1B recommendations, but administering a dose of antibiotics prior to incision, this should be within 60 minutes. Unless you're using fluoroquinolone or vancomycin, that should be within 120 minutes. And this is a 1B recommendation. This I thought was really interesting. They actually recommend against postoperative antibiotics in the 24 hours. So we commonly give prophylaxis for the 24 hours following a surgical procedure. Both the CDC and WHO have found that there's no great evidence that this is effective in reducing surgical site infections and has been associated with the complications of antibiotics, so C. diff infections and antibiotic resistance and allergic reaction. This is controversial. The Society of Healthcare Epidemiology of American Infectious Disease Society of America have both said that it should at least stop within the first 24 hours. There are some studies, especially in the cardiac literature, that surgical site infections can be reduced with that postoperative course for up to 24 hours. But after 24 hours, you should stop, even if there's a drain, and that's a 1A recommendation. It's important to maintain normothermia, keep blood glucose under 200, and using that increased fraction of O2, and for the 2 hours post-operatively. This is all thought to be to maximize the innate immune system, where the neutrophil, as it phagocytizes the bacteria, creates those superoxide compounds to kill those. And so those three things together optimize the function of the neutrophil. And that's a 1A recommendation. Preoperative patient bathing with soap, reducing the bacterial burden of the patient, and that can be medicated or unmedicated soap. It's a 1B recommendation. And then preoperative surgical site prep with an alcohol-based antiseptic, either alcohol iodine or alcohol chlorhexidine, just because the alcohol is so effective at killing bacteria. And so the takeaway points: wet scrub to start each day removes the spores, any organic debris that could inhibit the alcohol hand rub. But then after that, the alcohol-based hand rubs are superior, at least in the in vitro studies, looking at reducing bacterial burden. And then chlorhexidine alcohol has been shown to be the most effective prep of all the solutions. There's a lot of controversy to some of this, and that's because if you look at endpoints, the endpoint that we care about is reducing surgical site infection, but a lot of these studies that are recommending these certain products are just based at looking at how well they reduce bacterial burden, and that's not necessarily associated with the rate of surgical site infection. So there's no good study showing that any of these, iodine is less superior than chlorhexidine when it comes to surgical site infections, just at reducing the bacterial burden. But then that's kind of extrapolated that if you reduce the bacterial burden, that's probably beneficial to reducing surgical site infection. And then double glove and changing your outer glove every 2 hours is a pretty cheap and simple way to potentially reduce surgical site infections. So that'd be pretty reasonable. Now, Dr. Pottinger.
Thank you so much. I do hand hygiene for a living. I just learned a ton. So I'm really appreciative of that. And I'm very appreciative of the invitation today. For the record, I would have been happy to ski in February. It would have been fine. But I think Dr. Chansky was right to cancel. We had orthopedic surgeons getting in a car wreck to come to Grand Rounds. That's a bad look. So thanks for fitting me in today. I really appreciate it. We're talking about beyond bug juice. I have many conflicting interests. I'm highly conflicted how much time I should spend training fellows, seeing patients, climbing mountains, spending time with my happy family. But there's no financial conflicts of interest. It's antibiotics. There's no money. That's maybe the whole point. So we'll talk about the definition and epi. Yes, to continue on what Dr. Folchert has just said, the prevention issues. I want to talk about pre-op, what happens peri-op, and then this idea about a lifetime of preventative options for us. Really, you know all this already. I think it's more about just being here and getting to interact with you. To me, ID and ortho can't survive without each other. You may want to survive without us. We couldn't survive without you. You're our bread and butter, and vice versa. So my hope is that we can continue that strong collaboration, especially as our hospitals merge. What a great opportunity for us. Prosthetic joint infection is what we're talking about. There's so much more to orthopedics than PJI and prosthetic joints and total arthroplasties, but that's what we'll talk about today. So it looks like we're putting in about 1 million new hips, just hips and knees. Forget about shoulders, hips and knees. And that number is projected to get up to about 4 million by 2030. It's mostly osteoarthritis, although there are other indications. The map you see here provided by CDC is the rate of the embiggening of America. So this is our obesity rate state by state over the last 2 decades. It'll keep cycling through. The bottom line is that our bottoms are getting bigger, and the heavier we are, the more osteoarthritis we have. The more osteoarthritis we have, the more joints we're going to need to put in. So I think those projections regarding the burden and the need for our amazing trainees, you will not be out of a job because we just can't seem to lose the weight. We still need these joints. And the more joints we put in, the more infections we end up seeing. This is a spectacular case shared between me and Seth Leopold of a patient who had his knee and many years later decided that the knee was working great. So went skiing up at Stevens Pass and ended up with a blood blister, and the blood blister ended up seeding his blood and his joint. It remains to this day the single most profoundly positive gram stain of pus that I have ever seen. It happened to be something called group B strep, but could have been any particular bacteria. The big deal. These patients suffer a lot. The surgeon suffers. It's part of your business, but I know you don't like dealing with this. It's our pleasure to help. If we can do anything to reduce these, either at the primary time or down the line, I'm all about it. So what do we do pre-operatively to prevent prosthetic joint infections? We've heard a beautiful thesis about the importance of hand hygiene. I agree with that, absolutely. I think what we can do, what you could consider doing is what you already do. When you meet that patient, they come to you saying, my knee hurts, I want a new knee. That's fine. You have a whole bunch of things you're going to go through, but these are some of the things that I think should rise to the top of your list of considerations and concerns when you decide if this person is even a candidate for any kind of surgery, right? How big are they? Do they have diabetes? If so, is it well controlled? This depression versus psychiatric disorder, I haven't come across that in the literature, although I'm sure it's there. In my personal practice, this has been a huge opportunity for us to look at patients to figure out whether they really need a new knee or do they need an SSRI. I'm not saying that that will make them pain-free, but so often patients will somatize their concerns and they may have an opportunity with primary care to do other things along the line. As an orthopedic surgeon, you may end up diagnosing someone with depression even though they came to you for their osteoarthritis. More and more often, we have immunosuppressed patients in our practice. In your practice, it would be rheumatoid arthritis most commonly, but not just that. We have more biologics than ever before. It's stunning how many different ways we can crush the cellular and humoral immune systems. And when you're going to take somebody to the OR and open them up, that can have major implications. I think patients who have previously had a prosthetic joint infection, that's a huge concern. Obviously, the anesthesiologists have their thoughts. They have their entire scoring system. People who smoke, people who drink, people who use illicit drugs. We are in an epidemic, which is unprecedented in American history, with opioid use, and it may be a cult. They may not come to you with that in their epic chart of problems. You may be the one to figure that out. We'll talk about antibiotic allergies, and we'll talk about Staph aureus. The point is that in many of these indications, or many of these potential contraindications to surgery, there are things that can be done. It does not mean that it has to happen in the surgical suite. This is definitely a multi-part share. What is the old saying? It takes a village, right? That's true in raising kids. It's true in getting somebody to the table and successfully off the table with a new joint. So there are so many things that you could consider if you have a patient who you're considering taking to the surgery suite and you're worried that they may be on the fence. Work with us, work with primary care to try to address these issues if they happen to be addressable. I want to focus today on antibiotic allergies because they're so common, they're so painful, and they do come up in your practice. Then we'll come back to Staph aureus, and then we'll move on to intra-op. So regarding antibiotic allergies, 1 in 10 Americans will tell you that they are allergic to an antibiotic. It's usually penicillin, which is stunning to me because we don't use penicillin in America anymore, and yet this is what patients tell us. It's quite stunning. They'll say, I'm allergic to penicillin. If 1 in 10 Americans claims to be allergic, 10% of them are correct. 9 out of 10 times, if someone has an antibiotic allergy, it is not true. It is fake news, hashtag fake news. Why? Because they may have been told by their parent that they had an allergy. I have one of the fellows in my program says, I think I'm allergic. I have 4 siblings. One of us is allergic. We're all labeled because my mom can't remember which one. These sorts of shibboleths that get into the record get out there. It's a big deal surgically, right? So if you have, and I think I have this here twice, there's inferiority of Clinda or cefazolin versus a cephalosporin. If you can give someone cefazolin, is what you would like to give. If you give them clindamycin or vancomycin, a 50% increase in their risk of surgical site infections. Vancomycin, we love for its incredible breadth of gram-positive activity. It's not perfect. There is something called VRE, for example, but in general, if you're gram-positive, vanco will kill you, right, if you're a bacteria. But its cidal activity, its killing power is definitely inferior to that of the beta-lactams, like a first-generation cephalosporin, what we use in our hospital, cefazolin. If, in general, you can use a beta-lactam, that's the drug of choice. And these antibiotic allergies make it very difficult for you to order that. And this just is horrifying to me, makes me hopping mad, and it blows my mind that we still, as a society, have not figured out how to handle this. So the solution, yes, we do have skin testing. We have pre-pen skin testing. That is a thing that we have. In general, you want to test less, but talk more. And so often, these issues can be adjudicated right in the clinic. It should happen in primary care clinic and not an orthopedic clinic, but if you happen to deal with this, by talking to this patient, you can usually figure this out. What was it? If someone says that I couldn't breathe and I needed a tube in my throat, that really has my attention. If their skin fell off and they needed a skin graft, this thing called Stevens somebody, I mean, that gets my attention. But if it was a yeast infection, that's a different story. If it was nausea and vomiting, that's not an allergic reaction, right? Was it more than 10 years ago? Did it actually have anything to do with the dose that you got? Is it historical? Or you just told this when you're knee-high to a June bug by your mom, right? And so often, we see this, even if we delabel these patients, we see these antibiotic allergies coming back into the chart. It's usually driven by pharmacists in the community because they're pharmacists. I mean, they went into that practice because they have that sphincter tone. They're so precise and they're so worried that we're going to make a mistake. And so they'll put those antibiotic allergies back in. So the bottom line here is that if the reaction was not life-threatening, we can give them oral amoxicillin right in clinic. And in this particular paper, and I have the reference here for you, 95% of the time that was safe. And the people who had a reaction, it was a minor reaction at the point of care. What we are doing at UW Medicine is giving you, as surgeons, the opportunity to have these conversations ahead of time. If you're not sure what to do about it, we're building a pathway for you. Dr. Lahari Rampour is a board-certified allergist. She's on our faculty, and she has part of her FTE dedicated to this issue of preoperative antibiotic allergy adjudication. That's how seriously we take this opportunity. She's just joined our practice. What you will see coming to a clinic near you soon enough is going to be an algorithm you could use at point of care, and it has in part of that algorithm is when to give a patient a dose of amoxicillin or when to refer in to get the skin testing done with us. If you have enough preoperative time, we should be able to sort this out for you. So that's something that I'm eager to deliver to your practice in the very near future. This makes me happy, and what we've found over time with respect to our overall protocol, and this is already available to you through the Occam app online, is that if your patient had a serious cephalosporin allergy, consult an allergist. And if they had any serious adverse reaction, like their liver blew up or their face swole up, then they really, and if they didn't have any of those things, it's safe to give them a cephalosporin. If you go through this process, which is available to you, I will text you the thumbs up sign, the shaka sign, and the strong sign. I actually send this to the medicine residents when they go through this process. So it really does help get those patients onto the right bug juice as often as they can. This information does live for you on the Occam app that everyone has. Residents, are you down with Occam? Do you have our phone app on your phone? If not, I'll show you the link here in just a moment. Thank you. We've looked at this with respect to all surgeries that happened at our hospital in 2011. We've published this recently in Clinical Infectious Diseases, and what we found was that among patients who had surgery and got surgical antibiotic prophylaxis, those who had a beta-lactam allergy, there were 1,700 of them. Of those who were listed as having a beta-lactam allergy, 200 of them got cefazolin anyway, because they had gone through this process. In that particular case, it's fascinating. Some of them even had anaphylaxis listed as the reaction, but in conversation with the surgeon or the anesthesiologist, preoperatively, they didn't really believe that that was true, and they gave them cefazolin anyway. And none of them, not one, had a beta-lactam allergy on the table. Several of them had some kind of history, but those were not people who had a known previous beta-lactam allergy. It could have been the rocuronium, it may have been something else. The point is to say that these allergies are often not correct, and we need to give you easy-to-use tools to help figure that out. That's what we're committed to doing. The other thing I wanted to talk about in terms of preoperative risk reduction is Staph aureus colonization, both methicillin-sensitive and resistant Staph aureus. This is a common concern, and it should be, because patients who are colonized or have a previous history of Staph aureus infection, when it comes at least to hips and knees, we often do see them at an increased risk of getting a prosthetic joint infection due to those very difficult to treat microbes. It's the thing you're going to deal with in your practice, as do we. So here's an interesting study in which patients undergoing elective orthopedic surgery were pre-screened, and then those who had either MSSA or MRSA were decolonized to see what they could do with their surgical site infection risk rate. And what they found was that, yes, indeed, actually, if we look at both hips and knees, both MRSA and MSSA, those patients who had the Staph aureus who were decolonized, I'll talk to you about how they did that, their surgical site infection risk with those organisms was reduced, okay? In this case, down by 3/4, in this case, down by half, both MRSA and MSSA. The overall global surgical site infection risk rate was more than 50% reduced in this particular study. So it's very evocative. The idea is to say that if we know these patients have staph, we should deal with it before we take them to the operating room if we have the luxury of time. And in prosthetic joint implants, we usually have that luxury. So decolonization reduces the risk of surgical site infection. Decolonization can be extremely frustrating. I do not expect you to do it. I expect you to let us do it. It's a bit of a thing. And there's a lot that we don't understand. I'm showing the nose because that is where Staph aureus is classically thought to linger, especially the anterior nares where the hair is. Staph aureus likes hair. If you look at an electron micrograph of hair up close, it's an incredibly complex structure. It's not smooth, it's actually very crenulated. It has lots of hiding places for staph. I think that's why it likes it there. But the reality is, the more we look, the more we find staph. If you're gonna put in a hip, should we actually look at the inguinal fold? It's so close to the surgical site after all. If you're gonna put in a knee, should we swab the popliteal fossa? If you look at enough patients, you will find it there and not in the nares. There is no standard internationally or otherwise to say whether we should do that. Furthermore, as you may recall, Bactroban or mupirocin is the antibiotic we usually apply to the nares when we find this. When is the last time you saw a mupirocin susceptibility report on a Staph aureus isolate? The answer is never. It is not tested because it's very difficult to work with in our lab. On a research basis, when periodically staphylococcal resistance to mupirocin has been tested, it is very high. Almost half of these cases of staph happen to be mupirocin resistant, and yet we focus on the patient, put the mupirocin in your nose. It is literally a coin toss whether that's going to do anything. Believe it or not, mupirocin and chlorhexidine, as we heard before, these can be local irritants. They can, in fact, drive a local contact dermatitis, which is the exact opposite of what you want in somebody going into surgery. And we know that from studies in New York City where this has been looked at in preoperative orthopedic patients, most of them will not do it. They either don't get the prescription, don't fill it, or they're men, and so they don't follow the instructions, right? So if it's a patient-controlled process, it is unreliable. So that's why we often end up missing patients getting the full dose, even if the stuff worked in the first place. And when we've looked at this microbiologically, it may take up to 11 attempts of bathing the entire body, of scrubbing under the fingernails, going between the legs with chlorhexidine, or going to the nose. Up to 11 times it can take to ultimately get these patients decolonized. Are they sharing razors? They live on upper campus, they're sharing other articles within a dorm. It's such an easy to catch and to transmit germ back and forth. It can be very difficult. There is an emerging experience with intranasal povidone iodine. This is not the PI that you would get off the shelf. This is a gel. It's a metered dose where sterile gelatin is mixed in with povidone iodine. Those of you who practice at Harborview, you know this is routinely prescribed in preoperative holding at HMC. This is something that's probably coming to an operating room near you, both at Northwest and at UW for high-risk cases, and I would classify prosthetic joint implants as high risk as well. We like this technology because it's controlled by us. It happens in pre-op holding. The pre-op nurse does it and can check it off as part of their glucose euthermia. Are we going to do the right knee? All that stuff that we don't have to rely on the patient to do, we can control it. It does not eradicate Staph aureus. It suppresses it for 24 hours. And because that's when we think most of that healing is going to happen with the knee, that's why it is, in fact, associated with a surgical site infection reduction. That is currently at Northwest undergoing financial analysis. I think it's going to be very favorable. Seth Cohen is my colleague who is Director of Infection Control there. Many of you know Seth very well. He's terrific, and he wants to bring this technology to Northwest. I think that will be coming within the coming weeks or months, I hope. But regardless, please add vancomycin to your intra-op prophylaxis if they have a history of MRSA colonization. Let's talk about that in a moment. You also have, if you're doing elective joints at Northwest, this is the current iteration of how to handle Staph aureus preoperatively. This may now change in the near future to include intranasal povidone iodine, but more or less what it says is start here. Is your patient having any of the following, including orthopedic surgery with a joint implant? If so, do they have a history of any kind of staphylococcal infection, not coag-negative staph epi, but we're talking about Staph aureus, MSSA, or MRSA. And if so, was it real, for example, confirmed by the lab? And did that happen pretty recently? If so, these patients will get scrubbed aggressively. They will get peri-op vancomycin in addition to their cefazolin. And if not, we should take a look and see, do they actually have this present? That can be a swab with culture if it's performed with enough lead time to let that culture grow. If you have an urgent situation, we do have a PCR test that can be offered as well. The turnaround time is much quicker. You don't have to wait for those cultures to come back. Both of them are available to you at Northwest. If it's negative, you just go ahead and give them the cefazolin, but if positive, we would deal with that. Okay? Okay, thank you so much. So other things to do preoperatively, it used to be very standard for us to check urines. The concern was that if a patient has a UTI, they may be at risk for PJI, and that's what nobody wants, E. coli in your fresh knee or hip. This has been studied aggressively and consistently over time, and it's pretty clear now that this is actually a very rare reality. I would never say never to anything I'm going to show you. I think it probably could happen. But the idea is that if we see someone with asymptomatic bacteriuria and try to chase that with antibiotics, we can perversely make things worse by driving antibiotic resistance and actually putting them at an increased risk of a prosthetic joint infection. It's all about symptoms. If someone is in your practice and they say, it burns when I pee, I have urinary urgency, if you think clinically they have UTI, that case should be canceled, period. End of story. And that patient should see their primary care doctor, send them to us an ID, we will fix them. If they feel well, it's really don't ask, don't tell when it comes to the urine. I think it's, in terms of post-operative management, I think you're so smart about this already. We do love getting the Foley catheters out if they are placed at all in the first place. I think symptomatic UTI is different. That is a hard stop. These patients should not have surgery, but when it comes to asymptomatic bacteriuria, don't ask, don't tell. I think the choice of antibiotic does matter. We're talking about beyond bug juice. I'll just dwell on antibiotics briefly. I hope that our message today is consistent, that antibiotics, we debate about it a lot. We're trying to figure out the best way to do it. It's what I do for a living. It is a small part of this much bigger package, a comprehensive, multi-part bundle of best practices that would help to reduce the risk of the surgical site infection. But when it does come to antibiotics, they should be given on time. I'll give you a few more information points around that. And the drug of choice is usually cefazolin. If your patient can handle a first-generation cephalosporin, that's what we like. Bigger patients get a bigger dose. That's new as of 2015. And we do like to redose these patients every 3 or 4 hours. Patch Dellinger thinks it should be every 3 hours, and I happen to support that. WHO says every 4 to 6 hours. Based on the half-life of this medication, based on the duration of your case, and based on the amount of blood loss that you're going to see, every 3 hours is about right when it comes to redosing with cefazolin. The key is that this should be used as your frontline workhorse. If there is a MRSA history, regardless of what you've done to decolonize them, we would add vancomycin on top, but never replace the cefazolin with vanco unless we can't give cefazolin for a separate reason. All right, and that is a weight-based dose. This has a much longer half-life. We don't have to redose it except if it's going to be more than 8 hours. That would be unusual for the kind of cases we're talking about today. And again, as I mentioned before, if any of our residents, trainees have interest in adding the app to their phone, your friends can do that. I'd be happy to show that to you as well. All of our surgical site prophylaxis recommendations live in the SSI pre-op tile, the click that you do with your fingertip. That's all there. All that information is also hard-baked into the inpatient Cerner ORCA order set as well. If you have trouble with your pre-op order sets or you're not sure that they're working properly, let me know. We'd be happy to suss that out with you. On rare occasions, we run out of cefazolin, which is crazy and embarrassing and outrageous and unacceptable, but it has happened, including within the last year. And in fact, when I was going to give this lecture in February, we were in a cefazolin shortage crisis, in which case we can switch to ceftriaxone. We don't like to do that for hips and knees because ceftriaxone is more broad than you would need. Ceftriaxone is okay for Staph aureus. It's great for gram-negatives. It's rare that you would have a gram-negative prosthetic joint infection. So if you do end up in that situation, it is a single dose which lasts for 24 hours. Ceftriaxone, our workhorse and the cephalosporin of choice in shoulder infections and in primary and follow-up revision shoulder, because we have this other creepy germ that you would virtually never see in hips and knees called Cutibacterium. C. acnes or Propionibacterium acnes in Winston, and Dr. Warm, Dr. Mattson, Dr. Shu and I have wrestled with this germ over a long period of time. So in shoulders, we actually do use ceftriaxone because it's a better killer, I think, of Propionibacterium, but otherwise it is not typically to be used. I won't belabor this, but it's absolutely true that our risk of surgical site infection is lowest if we can give that dose as close to skin incision as we can. That's been modeled many times and published in JAMA and elsewhere. WHO agrees with this just exactly as Dr. Folchert mentioned before. This is another and I think you mentioned this very nicely, it's another bad side to vancomycin, or God forbid, a fluoroquinolone. The thought of a quinolone in your patients just makes me hopping crazy with all the tendinopathy, et cetera. But those take longer to infuse, and getting that timing right, doing it 2 hours before the skin incision, it's a challenge, right? With respect to working with our wonderful teams in pre-op holding, it's hard for them to do this. That is a very real concern. Other questions that have come up, there's some hot topics. I'd actually be happy to talk about some of them. I wanted to raise, this is exactly what Dr. Chansky said, I wanted to raise this meeting, the International Consensus meeting, and Paul Manner was so kind to invite me to join in Philly last year. It was so fun. This is the biofilm working group. There were so many working groups. These are surgeons from around the world and a handful of us ordinary ID doctors who got together to talk about issues related to prosthetic joint infections. It was a terrific experience for me. What came from this is a large consensus statement. I think it's a 300 or 400 page PDF. It's free, it's open source, and it is cooked into an app. So if you want to actually get a hold of these guidelines, you can just look up ICM Philly on the App Store and get easy to use searchable access to it. But what came from this so-called Delphi model, questions were asked ahead of time, and they were then voted on in subcommittee and voted on in larger committee as well. So these are some of the things that come up in questions that I get from surgeons. One of the questions that was asked, is there a role for the use of antibiotic impregnated cement in primary total joint arthroplasty? The recommendation, yeah, absolutely. It can be used in primary TJI to reduce the risk of surgical site infections. The benefits of impregnated cement versus its cost and other adverse effects may be most justified in the patients at highest risk of infection. In my experience, so many of the patients that we take care of at UW Medicine would fall into that high-risk category, probably for a variety of reasons, but if you think back, I should have included that list, but diabetes, immunosuppression, uncontrolled severe immune defects, et cetera, many of our patients, I think, would fall into that category. So I don't have any problem recommending that we do stick antibiotics into the cement. What we could not decide on as a group at this particular meeting was what the best antibiotics are. Generally speaking, something to cover gram-positives is the right way to go. I think that should be vancomycin. I think it's extremely unusual for us to have the antibiotics cause renal injury, although I think I've seen that in my practice on rare occasions in the past. If you're going to reach for anything, vanco would be the thing that would be most rational and I think easiest to work with in the operating room as well. What we didn't even talk about, it didn't occur to me until we went home, unless Paul, you may have a different recollection, but I don't think we even talked about antiseptic or antibiotic lavage into the joint. I couldn't find this, and in fact, I looked at it again last night. It's such a common question. We should have talked about this. There were just 1,000 things that flew by. So what is the story? What should we put into the joint at the time of primary implant to reduce the risk of surgical site infection? We don't know. There are some small studies which have not shown benefit, but they were small. And so they do not definitively rule out the idea that this could be helpful. The WHO itself says, based on these previous studies, we should consider dilute povidone iodine going into the joint. There is this nice paper, which technically was published just last month, but I think electronic versions came out several months ago. Some of you may have seen this. I like this a lot. So this is revision. This was not in primary. This was in revision surgery, which is a different beast. But these are patients who had total joint arthroplasty lavage, and they were randomized to either get lavage with saline or lavage with sterile 0.34-0.35% povidone iodine. Now in that series, there was a substantial reduction in the risk of prosthetic joint infection for those who had the iodine, 0.4% risk of infection, versus saline, which was 3.4% risk of infection. So the implication is that if you can get your hands on sterile, dilute povidone iodine, it is worth considering folding that into your practice. If you want to do it, if you feel that you need to do that, and if you can get your hands on it. We were just chatting about this a few minutes ago. Right now, it's very diverse. At some hospitals, you can easily get sterile povidone iodine. At others, you cannot. And so that's a barrier. I don't like that. I think we need to fix that. I've talked with Seth Cohen about this at Northwest, and I think he's interested in addressing that issue as well. What's the deal with sterile povidone iodine? We talked about how antiseptic it is before. How could anything live in there? It's just a stunning reality that there are gram-negative rods like Pseudomonas aeruginosa and Serratia marcescens that live in povidone iodine. And that is horrifying because just think about the ionic stress that there's just so much iodine, it's hard to believe anything could survive. But there are some bad-looking bugs. Those are the exact bugs that you totally don't want in a joint. So if it's not sterile, I would not put it in. But if we can get a hold of sterile povidone iodine, it's something worth considering, or at least talking about internally among yourselves and deciding what you want to do about that. I think that's perfectly reasonable. And then I think there's all the stuff that happens in the operating room that we talked about before, that nice list of things, the factors that are controlled largely by our colleagues in anesthesiology. Have we gone through the checklist? What's their sugar, or what's their oxygen tension, et cetera? I think that tight collaboration between surgery and anesthesiology, it's got to be the best symbiosis example of anything on any organization I can think about. If you are right with anesthesia, then things will go right with respect to these risks. If things are not going well between surgery and anesthesiology, that is a huge opportunity for discussion, improvement, and making sure those communications are tight, because you're going to be so worried about those technical details. We should just assume that anesthesiology is able to handle these issues. And maybe they are, and maybe they are not. I know that having worked with them for many years, not only in ortho, but in general surgery as well, they're highly committed to doing the right thing. Periodically, it's okay, I think, to have those discussions if you think things may not be going as well, or just to look at the data that they've got. Every one of these features is tracked for every single case. As the surgeon of record taking care of this patient, I think you're entitled to that data to see how our colleagues are performing with respect to all of these particular metrics. Then the question that came up a short time ago as well, what about antibiotics? I'm thinking about postoperative and perioperative opportunities. Duration, I think, matters. This question that comes up, we won't belabor this too much. Should we continue antibiotics after the incision is closed? So as you heard a short time ago, there is diversity. The WHO, the CDC, the Surgical Infection Society say no, but that's really through the lens of general surgery, especially colorectal, and some plastics. Orthopedics is different. Think about the implants that are going in, the relative lack of vascularization of that surrounding tissue, et cetera. So the AAOS and the MSIS say, actually, the absence of evidence is not the same as evidence of absence. We are not clear that we should go with a single dose. And what came actually from that most recent consensus guideline that we were talking about in Philly is take a day. You can stop if you choose to do so after the patient is closed in the OR, but it is completely reasonable for us, until we get better high-quality data, to proceed with 24 hours of antibiotics. So at least that's what we have said at the consensus statement. And then once in a while, there'll be something that shakes up that idea. So here's a paper that may have come your way as well. I wanted to talk about this. So these are investigators in Indianapolis. I actually am not colleagues with any of them, but they seem like they're terrific surgeons. And all surgeons, there's not an ID doctor involved here. They didn't have to. They knew what they were doing. It's a well-designed study. I like that a lot. And what they looked at was patients in their practice undergoing a hip or knee implant who were at high risk for prosthetic joint infection. High risk meaning that they were very large, very diabetic, very smoky, very bad kidneys, very bad immune system, and or had had nasal colonization with Staph aureus. And these patients either got 7 days of oral cefadroxil or Clinda or Bactrim. They chose an antibiotic for a week, PO, based on the history of that patient, what they could tolerate, what their prior antibiotic resistance profile looked like. And then they were followed for 90 days. And this is a pre and post design study, not randomized, but pre and post. And here's the fabled table one. Number one, the groups were matched very well. The patients who got more antibiotics had more diabetes and they had more Staph aureus colonization. This would tend to favor the pre-group, if you will, but otherwise very well matched. And the bottom line was here. If we look at patients here who received antibiotics, they were broken down by how many of those risk factors we had of the ones I listed before. You can ignore 3 because they had very few of these patients, but those with 1 or 2 risk factors, here's the column of those who got extended here's the column of those who got extended antibiotics versus those who did not. So there was a substantial risk reduction in patients who got a week of antibiotics versus those who got just the 24 hours in their pre and post design. This suggests that longer antibiotics may indeed be better for this particular patient population. I would simply emphasize that their surgical site infection risk rate pre-intervention was at 2 to 5%. And that may be different from our outcomes and our current experience here at UW. We'll come to that. Furthermore, whether we looked at hips or knees, again, there was that difference between those who got antibiotics for a longer time and those who did not. 11% in this particular subset of their patients were getting a surgical site infection. Is that because it was Indiana, and you can find it on the map for yourself? Is that an obesity thing? Is there something else that's going on in this particular practice? I would suggest to you that if in your practice you had an 11% surgical site primary joint infection rate, that would be an emergency. We would actually get inspected by Joint Commission. So I think it's not clear to me that that's exactly what's happening with us. Here's data provided to me by Seth Cohen, our director at Northwest for surgical site infection prevention. And what he's found is that if we look at surgical site infections, whether we're talking about superficial or deep, this is just deep organ space infections, you want to have a surgical infection ratio that's less than 1. That means that some smart person has compared our cases with complexity matched cases nationally, and a ratio of 1 means we're average, less than 1 means we're better than average, more than 1 means we have more infections than we should. So at Northwest, looking back from 15, 16, 17, and 18, we're consistently less than 1 over that time frame. And this is true overall, but looking at hips and knees in general, and I'm sorry I do not yet have 2019 data. I think that's undergoing analysis now. We're getting there. But again, your surgical infection rate just at Northwest, what you're doing is below 1. So a different patient population, perhaps, I think maybe more virtuoso surgical technique. There's probably a variety of things that are going on to show why we are superior. The number of infections that we had in 2018, there was 1 MRSA and 1 MISA, and 2 coag-negative staph. The rest were a smattering of other things that may have related more to postoperative care than intraoperative surgical infection opportunities. So I think for me, the bottom line of this study, very intriguing. I think they had a very high risk, very obese cohort. The antibiotics of the harm was of the greatest concern. How much C. diff did they see? How much resistance? Allergic reactions. It wasn't even studied because there was not an ID doctor involved, but that's fine. In terms of the actual outcomes, I think it's an opportunity to look at our own data. That's what we're doing currently at Northwest with Seth Cohen. And if we see that there is an opportunity for us to do something similar, we would be open to discussing that. Yeah, so going back to the recommendations here, I just wanted to put that up there for your for your review. Antibiotics are not necessary for drain prophy, as was mentioned. That's a separate animal. We really do not recommend that. I know many of your patients do not come out with a drain. It just depends on a variety of factors. The bottom line for me, 24 hours of post-op antibiotics for most of our patients with primary total joint arthroplasty, which is exactly what we said here. Then in terms of lifelong healing and care, I think it's, that we focus so much on the operating room, which is appropriate. I think the patient has to partner with us and do their part to take care of themselves. And there's such an emerging information to say that if patients are not taking care of themselves, their risk of all sorts of bad things happens, not just heart disease and cancer and stroke, but also prosthetic joint infection, right? So oral health is one of those things that comes up. This has been controversial. This is a change in our practice recently. It is true that there is a risk of prosthetic joint infection with oral flora seeding from the gums to the blood to the prosthetic joint, but this turns out to be extremely rare. Indeed, rare enough that the AAOS and the ADA, American Dental Association, agree that although we used to give patients antibiotic prophylaxis for routine dental care, we no longer recommend that. We do recommend it for patients at increased risk for reasons I'll describe for you in a moment. If I were to ask you about the relative risk of bacteremia, just bugs in the blood, from a variety of different oral risk factors, if we use tooth extraction as a relative risk ratio of 1, you may have a mental model for yourself about what dental exams can do to the bloodstream. And this is just how we're going to look at colony-forming units per minute, per mil, per year. Tooth extraction as 1, just as an arbitrary relative rate of 1. Dental exams do increase that risk, but they are exponentially less than what we see in just everyday daily life, including dental flossing, chewing. The dropping of an NG tube is basically risk-free. So the point is what patients do with their daily life and what they should do with their home care is much, much more important and potentially more risky than what happens in the dental office. So current guidelines emphasize that daily activities incur the highest risk, and we can use the same exact data set around endocarditis prophylaxis that we do with prosthetic joints. And that's where this consensus guideline comes from. In general, for patients with prosthetic joint implants, prophylactic antibiotics not recommended prior to dental procedures just to prevent the joint infection. There are exceptions. This is a case I think some of you worked on with me of a man. It's just a man who lives by himself. Why he had a Christmas tree, I don't know, but he went back to the Christmas tree sometime in January, got hungry, picked off this stale old candy cane and bit down on it. He did fracture his jaw, ended up having a huge hematoma. It's obviously a fracture. And then sat on it because he's a man who lives alone for a week. And of course, he did become bacteremic. His prosthetic joint became seeded with a whole family of oral anaerobes. So, and this caused a huge mess. This had to be washed out. It was a whole thing. So oral infections can indeed cause prosthetic joint infections. They're very rare. Patients should not eat stale candy canes, fracture their jaw, and then sit on it for a week. So there are exceptions. But in general, the time we would give antibiotics would be for patients with HIV that's untreated, patients undergoing chemotherapy, patients on biologics, patients who've had solid organ transplant, are sickest of the sick. Otherwise, in general, we're not currently recommending antibiotics for those patients. So I know it feels like this a lot. That's how we roll. I would just emphasize, I'm just so appreciative of the time I get to spend with you because, I think this partnership we have around this, we're all in hell together, put it that way. Your current practice is already superb, as I've shown you your own data. No pre-op urine workup if they're asymptomatic. Cefazolin, that's what's for dinner. Penicillin allergic patients, we are, I promise you, in the process of delivering you point of care tools that you can use in your practice. We rely on the anesthesiologist to do the right thing with antibiotics based on your orders at the right time. Generally, we stop them within 24 hours. If they have a drain, that doesn't matter. The opportunity is to look for risk factors with the handful of SSIs that we do have and to see what else we can do to try to reduce that rate, chasing the proverbial zero. I know we're at the end of the hour. I have time to stay before my parking runs out. I'm happy to talk with you about any of these issues. I would also welcome any comments or concerns or thoughts to my email. It's abx@uw.edu. And thank you so much for your time.
They do start ticketing at 8, so we have to be a little careful, but we have a few minutes for questions.
Sure.
I certainly have a lot. But That was fantastic, both of you. My question is, one of Dr. Pottinger's last slides caught my attention, and it looked like you were saying lifelong antibiotics for patients with autoimmune diseases like RA on DMARDs.
Who go to the dental office. So for
Okay,
patients
just
who are
associated with-
patients who are those were factors whereby you might actually consider giving these patients dental prophylaxis.
Okay, got it.
But not for life otherwise.
Got it. My other question or comment is, or maybe opportunity for changing our policy or even a study, is that I would say more often than not, when I walk in the room, our patients don't have a mask on. There seems to be this sense that, patients are maybe immune to their own bacteria. So we're all masked, and if we ever walked in the room without a mask, somebody would scold us. But I often have patients that are, bent over for quite a period of time getting a spinal. And so I think throughout our system, we need to have a policy that patients should never get into the operating room without a mask on. So just something that
That's fascinating. Never
we can
even
talk
occurred to
about
me.
or look into separately. My other comment, going a little bit off topic, is that in all of our cases, our instruments are typically soaking in a pot of bloody saline. And I would imagine by the end of every one of our cases, those are pretty heavily contaminated, particularly for something that's going a little longer than 90 minutes to 2 hours. And so we're probably using things that have some bacterial contamination on them towards the end of our case. And again, something that perhaps needs, a resident with, the ID team to look into.
It's a fascinating idea. I mean, that is, I'm sure that's true. And of course, that's the rationale for the perioperative antibiotics.
Yeah.
And if we do surgeries without antibiotics, most patients come through fine, but that rate of infection is higher. This is probably a great explanation for why that happens.
Yeah.
Is there a routine practice for changing instruments after the skin is cut? Are there other stop points?
Well,
during the
typically
case?
we'll, discard the scalpel that we use for the skin, but we accumulate lots of instruments that we need as the case goes on, and the nurses will wipe them down, but there's nothing being done to really decontaminate them. And it's one of the reasons that if I were having a total joint, this is not based on any study, particularly a revision that went on for some period of time, I don't think one single dose is enough. I'm sure even at the end of those cases, that literature better than I do. Even our incisions are contaminated, at some point into a case. And so it's somewhat related to the issue of just using a single dose for total joint replacements.
I'm with you. Thank you.
There's a lot of literature right now on povidone iodine, dilute povidone iodine in total joints and spines. Can you explain how that works if we know that it's an exothermic reaction and it needs to dry to kill the bacteria,
cannot.
which
Yeah,
has
thank
been
you.
shown in a number of studies?
Doesn't make a lick of sense, does it? It's just as you mentioned before with respect to iodine and also alcohol, it's supposed to dry out and therefore fix or kill the bacteria. So getting into a swimming pool like this, I cannot explain how that works. Not really. That's why I think that result is a bit surprising. So I feel you.
Good morning. Thank you both. Very, very high yield presentations. I missed the first couple minutes of Dr. Folchert's lecture, so I apologize if it was covered, but one of the things we use pretty frequently is Ioban. So Ioban, and again, I don't know, I had read some stuff that, the environment, the anoxic environment may actually increase bacterial load, much like these gloves. You mentioned scrubbing with iodine and then wearing gloves for hours. So again, I apologize, but I did want to follow up on that.
That's a great question. What's your thought?
Yeah, so some of the studies that have looked at it, again, not great studies, but anytime you have an occlusive wrap over the skin, the resident bacteria that kind of live in the skin come out and can multiply. The Ioban has iodine in it, so it does have some bacteriostatic effect. The non-iodine impregnated wrap, if you try to colonize skin surface underneath that, they typically have pretty high bacterial counts. And so I did come across several studies that recommended against occlusive coverings of the skin. There are some studies in the joint literature that find that using Iodine to cover the skin potentially does reduce the rate of infection. And I think it has probably more to do with how it's applied. In those cases, if you can maintain that Iodine over the skin, kind of away from the incision itself, then it probably does reduce your risk. But if that Iodine comes loose or is moving around or fluids kind of running underneath of it, then that's probably potentially a big source of contamination.
Thank you.
Is Iodine universally used? Is that a routine thing for virtually everyone? Seems like it's been that way since I was in med school. I love the idea that we look periodically to sit at the evidence to support what we're doing, and it's fascinating.
Any other questions?
Thank you so much.
Thank you, that was wonderful.
Okay. Matt, thank you. Your lecture's great.